Today, we're pulling back the curtain on one of the most fundamental skills in all of medicine, the gastrointestinal examination. But listen, we're not just going through a checklist. We are going to treat this like a true medical detective story, where every single observation is a clue to what's really happening inside the body. So let's start the investigation. It's a great question, isn't it? Because it's definitely not just random poking and prodding. It's a really systematic investigation, a sequence of 4 key steps that are designed to gather evidence without, and this is key, disturbing the scene. And just like any good detective, the doctor's on the lookout for patterns, for anomalies, and for all those subtle signs that tell a much bigger story. All right, so before any investigation can even begin, you have to set the scene correctly. And in medicine, that means creating an environment of trust, of comfort, and total respect for the patient. It's the absolute foundation of a good physical exam. So these 3 steps you see here, they're non-negotiable. First off, the doctor explains exactly what they're going to do and gets your consent. Simple as that. Then, they make sure you're comfortable. Usually that means lying flat with your knees bent a little bit, because that helps relax the abdominal muscles. And finally, appropriate exposure, from about the lower chest down to the upper thighs, which gives a complete view while still maintaining your dignity. It really is a partnership. Okay, the stage is set. Now the investigation really begins. And just like a detective scanning a crime scene, the very first step is a purely visual sweep. This is the inspection phase. And honestly, you would be amazed at what can be learned before a doctor even touches the patient. The doctor is just looking. They're looking at the overall shape of the abdomen. Is it flat? Is it maybe a little sunken, which could hint at malnutrition? Or is it distended, swollen outwards? They're also scanning for scars from old surgeries, any discoloration, or visible veins. These are all the first clues that start to build a picture in their mind. Now, when it comes to a swollen or distended abdomen, doctors often use this really handy mnemonic to run through the most common possibilities. They call it the 5 Fs. It's a quick mental checklist. Is the cause simply excess fat? Is it fluid, a condition we call ascites? Could it be flatus, which is just a fancy word for gas? A fetus, as in a pregnancy? Or, the more ominous one, a fatal mass, meaning a tumor. It just helps them quickly narrow down the suspects. And speaking of visual clues, this is a really dramatic one. It's called caput medusa, which is named after the mythological figure with snakes for hair. And you can kind of see why. These are not normal veins. They are swollen and radiating out from the belly button because blood from the gut is having trouble getting through a scarred-up liver. It's being rerouted. This is a powerful, unmistakable sign of severe portal hypertension, usually from something like cirrhosis. A single visual clue that just speaks volumes. So after that visual sweep, the detective brings out the next set of tools. Their ears for listening and their fingers for tapping. This is auscultation, listening with a stethoscope, and percussion, that tapping technique. It's all about listening for hidden codes and trying to map out what's lying just beneath the surface. And this right here perfectly illustrates the logic of the exam sequence. A detective wouldn't want to trample all over the evidence before analyzing it, right? Well, it's the same idea. A doctor listens before they press on the abdomen, because touching and pressing can stir up the bowels, creating gurgles and sounds that just weren't there before. To get a true, accurate reading of the gut's natural activity, you've got to listen first. So what are they listening for? What is the gut telling them? Normally, you should hear a nice, gentle gurgle every 5 to 10 seconds or so. That's the sound of a happy, working gut. But the abnormal sounds, those are the key clues. A high-pitched, almost tinkling sound can suggest the bowel is stretched out and really struggling against a blockage. And then there's complete silence. After listening for at least 2 minutes, nothing. That can mean the bowel is just shut down, which is a very serious condition called an ileus.
After listening, it's time to tap. Percussion is kind of like tapping on a wall to find a stud. Over a part of the bowel that's filled with air, the sound is resonant, almost like a drum. But over a solid organ like the liver, it's dull. Shifting dullness is a really clever maneuver. The doctor taps out the area where the sound is dull, then has the patient roll over onto their side. If that dull sound shifts down with gravity, well, that confirms there's free-floating fluid or ascites in there.
So we've looked, we've listened, we've tapped. Now it's finally time for palpation, the hands-on part of the investigation. This is where the detective can actually feel for more subtle evidence, things like tenderness, masses, and the size and texture of the organs themselves. Okay, so let's say the doctor feels a large mass in the abdomen, but what is it? This table shows how a few specific clever maneuvers can help tell them apart. For an enlarged liver or spleen, for example, you can't get your fingers above them because they're tucked up under the ribs, but you can get above an enlarged kidney. An enlarged spleen often has this distinct little notch on it you can feel, while a kidney is ballotable, which is a wild word, but it just means you can kind of gently bounce it between your two hands. It's a really brilliant piece of diagnostic reasoning.
Now, this is one of the most important signs a doctor looks for. They press down slowly and gently, and then they quickly let go. If the pain is a lot worse on that release, that's what we call rebound tenderness. It's an incredibly strong clue that the peritoneum, that's the sensitive lining of the whole abdominal cavity, is inflamed. And that could point to something serious like appendicitis or even a perforation. So, we've gathered clues from inspection, from auscultation, percussion, and palpation. The final step in any investigation is to put all the evidence together, right? This is where all those individual findings combine to point towards a specific diagnosis. It's time to solve the case. Let's look at a classic case to see how this works. The detective's investigation turns up two key findings. Number one, the patient's skin is yellow or jaundiced. And number two, the doctor can clearly feel an enlarged gallbladder in the right upper part of the abdomen, but it doesn't hurt when they press on it. This very specific combination of clues is extremely powerful. And this is where it all clicks into place. This set of findings is famously known as Courvoisier's law. Basically, it states that if you have a gallbladder, you can feel, it doesn't hurt, and the patient is jaundiced, the cause is probably not a simple gallstone. Why? Because gallstones tend to cause chronic inflammation that makes the gallbladder all scarred and shrunken, not big and enlarged. This finding points the investigation further down the pipeline, often to a blockage caused by something like a mass in the head of the pancreas.
So we've seen this whole incredible toolbox of techniques, right? From simple observation all the way to this complex reasoning. It's an impressive system. But what is it that ties it all together? What is the ultimate tool that turns all of these little clues into a coherent diagnosis? At the end of the day, the answer is the clinical mind. The signs, the sounds, the feelings, they're all just data points. The single most powerful tool is the physician's ability to synthesize all of this information, to weigh the possibilities, and to use their years of experience and knowledge to solve the case. The detective story of the GI exam is ultimately a story of human expertise.